All right, welcome to This Explainer. If you've ever felt that familiar wave of dread when a patient sits down and says, "Doctor, I'm dizzy," well, you are definitely not alone. Dizziness takes up a massive chunk of primary care and emergency visits. But here's the thing, the absolute highest yield change you can make in your practice isn't necessarily mastering some complex new treatment. It's actually just referring more selectively. The real secret? Refer based on the specific syndrome, not just the symptom. And today, we're going to map out exactly how to do that.
Picture this scenario. You have a patient presenting with dizziness. You could send them to ENT, you could send them to neurology, or maybe even a geriatrician. The trap we all fall into is that vestibular medicine sits at this incredibly messy intersection of specialties, and there's no single obvious owner. If you send them down the wrong path, consumer data shows they could end up waiting over 18 months, just bouncing between 3 or 4 different clinics. Ultimately, only one of those providers is actually going to give you a useful answer for their specific condition. So how do you choose?
Okay, let's dive into this and build our mental map. First, we'll look at staying in primary care. Second, the vestibular physician pathway. Third, ENT and surgical referrals. Fourth, when to loop in neurology. And finally, some crucial guardrails and tips. Here is the core paradigm shift you need to make. The word dizziness, all by itself, does not select a specialty. It just doesn't. Instead, it's the pattern of triggers, the duration of the episodes, and your bedside signs that actually dictate the specialty. Positional vertigo maps one way, while recurrent vertigo with hearing changes maps completely differently. This is what we call the syndrome to solution framework. All right, part 1, staying in primary care. Believe it or not, the literature shows that a surprising 60 to 70% of all vestibular presentations seen in general practice can actually be managed right there in the community. So when should you hold on to these cases? Well, for BPPV, refer them out only after 2 failed positional maneuvers. For vestibular migraine, start with lifestyle tweaks and a preventer. You only need to refer if they're still struggling after 2 solid prophylactic trials. With vestibular neuritis, initiate symptomatic management and early rehab, and refer if recovery is dragging on past 6 weeks. And for orthostatic or medication-induced dizziness, tackle the blood pressure and medication review first. The point here is, dizziness alone does not mean you need an immediate tertiary referral. Let's see how this actually plays out in practice with a quick vignette. Say you've got a patient who gets brief, room-spinning vertigo every time they roll over in bed. Okay, that's positional vertigo. You do a Dix-Hallpike test and it's positive. You treat it right there with a single Epley maneuver. 60 to 80% of the time, that one maneuver completely resolves the symptoms. This perfectly matches the patient to the primary care provider. There are no wait lists, no specialist fees, just immediate relief. Moving on to section 2, the vestibular physician pathway. Now, when the bedside diagnosis gets a bit muddy or your first-line management fails, this GP with special interest model is an absolute game changer. It literally unblocks the congested medical system. The vestibular physician is there specifically to absorb those complex, tricky cases where you've already done the basic workup. They are your go-to for diagnostic uncertainty, for BPPV that just won't clear up after a couple of Epleys, or for suspected PPPD, that's persistent postural perceptual dizziness, that needs a firm diagnosis and a structured rehab plan. They take on the non-surgical chronic dizziness cases that usually bottleneck our tertiary clinics. Let's contrast the old way of doing things with the new way. Historically, you might send a refractory vestibular migraine to a public ENT. But because there's no surgical question and no hearing loss, they get slapped with a Category 3 priority. They end up waiting 6 to 12 months only to get a perfectly normal audiogram and get sent right back to you. By routing that exact same patient to a vestibular physician instead, you get a rapid diagnostic consult and immediate medication initiation. You're simply matching the clinical need to the provider's actual strength. Which brings us to section 3, ENT and surgical referrals. So if we're diverting the non-surgical dizziness away from ENT, who should we be sending them? You want to utilize your ENT and neuro-otology colleagues strictly when a structural or surgical intervention is on the table. We are talking about severe, refractory cases of Ménière's disease that might actually need intratympanic gentamicin or endolymphatic surgery. We're talking about vestibular schwannomas spotted on an MRI that need combined neurosurgical and otological care. Or structural defects like superior canal dehiscence syndrome and otosclerosis. Their incredible surgical expertise shouldn't be wasted on a straightforward migraine, right? Here's what that looks like in the clinic. A patient comes in with episodic vertigo, but this time they mention a new asymmetric hearing loss and maybe some roaring tinnitus.
That combined presentation of vestibular and conductive or sensory neural features is an absolute red flag. It maps immediately to ENT. Because you suspect Ménière's or maybe a schwannoma, you bypass the vestibular physician entirely and refer straight to otolaryngology, making sure to include the relevant imaging.
All right, section 4, when to refer to neurology.
Just like ENT has a very specific domain, neurology handles a very distinct subset of the dizzy population. So, the crucial point is that neurology is strictly for diseases of the central nervous system, or when the vertigo is accompanied by other dispersed neurological features. Think about suspected multiple sclerosis in a young adult who has recurrent vertigo along with optic neuritis, or progressive cerebellar ataxia, or maybe a patient who had a posterior circulation stroke and needs risk factor management beyond that acute window. If the inner ear is not the primary culprit, neurology is your destination.
Finally, section 5, guardrails and tips.
To make sure you don't accidentally swerve into the wrong lane here, I want to give you a firm do not refer list. First up, do not refer pure hearing loss with any vestibular features to a vestibular physician. That strictly belongs to audiology or ENT. Second, do not refer a vestibular migraine to a generalist neurologist unless you've confirmed they actually have a specific interest in vestibular medicine. Generalist neurology practices often just don't focus on vestibular disorders, and your patient might end up right back where they started. Always match the skill set to the syndrome.
Now, what's really interesting about this whole process is that it all kicks off at step 1, the structured history and the bedside exam. We are literally talking about a focused 5-minute assessment. HS, INTS, Dix-Hallpike, head impulse, and checking orthostatic blood pressure. That 5-minute investment is the absolute highest yield tool you have. It alone resolves the diagnostic question for the vast majority of dizzy patients and triggers this entire logical referral matrix we've been talking about. If you take literally nothing else away from this explainer today, please let it be this core anchor phrase. Match the syndrome to the provider, not the symptom word. Dizziness is just a symptom, it's a feeling, but acute vestibular syndrome with hearing loss, that is a syndrome. When you clearly define the syndrome, the correct specialist makes themselves completely obvious. So now you know exactly who to refer your patient to, but how do you get them to the top of the triage pile? In the next part of this explainer series, we're going to close the loop. We'll cover exactly how to write a highly effective referral letter that clearly states your clinical question, how to navigate those tricky urgency tiers, and crucially, how to safely manage your patient while they're stuck on a wait list. I want to leave you with this provocative thought. Tomorrow morning, when your very first patient sits down and says the room is spinning, are you going to refer them based purely on that symptom? Or are you ready to categorize their syndrome and match them to the exact right provider? Thank you so much for joining me for this explainer. To explore more about dizziness, vertigo, and imbalance topics, and to access some incredible clinician resources, be sure to check out AustralianDizzinessClinics.com. See you in the next one.